Laura,
Hello, hello.
in a while, how are you?
I know. How are you doing?
Good.
Yeah, good.
PTO, the
What?
best. So I'm on PTO, it's the best.
Are you on this? What are you doing presenting?
It's minor. I
Okay.
I cannot not do work anyway, so
Oh, boy.
But you have to start counting this as work.
no, this is good balance.
Hi, you guys. How's everybody?
Hello, hello.
Hello.
Hi, everybody.
Hi.
Melissa and I were together, so she's making her way with me. Fred, we were thinking of having you go and then Jenny. Does that work for you?
Sure.
Cool. Okay.
All right, let's give people 1 or 2 more minutes. Hey, Patty. All right, I think we'll go ahead and get started as we have 2 great presentations planned for today, so we'll want to use the whole time. Just briefly, 2 things. Hopefully, you saw my email earlier, and if you haven't had a chance to have Caitlin let you know that she's moving on to another job, so very grateful for Caitlin's efforts. Do you want to say where you're going, Caitlin, in case people didn't see and when?
Sure. Yeah. So thank you. Melissa sent out a very kind email earlier. I am moving to a role at the very same health system where I was born in Southeastern Massachusetts, working on health equity programming throughout the system. So it's a community facing role in a community that my family's been in for many generations, and I'm really excited, but we'll miss this team so much. It's been a absolutely incredible several years. I hope to stay in touch with all of you and continue to see all of the amazing work that you do. And I'm just very thankful. So been a harder transition than I could have ever anticipated, I have to say.
Well, we wish you luck. So thank you, Caitlin.
Thank you.
Let's see, and Will, was hoping that you could, we have some good news on the Pepper pilots. I know most people have been contacted directly, but do you want to just say what was awarded this cycle?
Yeah, sure. So we have 3 fantastic award projects this cycle. So the 3 projects were led by Dr. Shara Winter, Louisa Holiday, and also Nihal Mohammed. The first project is on understanding discharge destination decisions from patient caregiver perspectives and in the context of social determinants of health. The second project is defining a cohort of chronically ill patients with repeated hospitalizations for future research on segregation of care. And then the last one is actually somebody from urology, in the urology field, improving psychological adjustment and care quality for men on active surveillance. So really look forward to your fantastic work in these projects, and look forward to future presentations as well.
Great, thanks, Will. Yeah, we can tee those up either as kind of presenting what the work will be, or depending on the schedule, kind of maybe a work in progress after some time has gone by. So we look forward to hearing more about those projects. I think let's get right into it, since we have two for today. Who's going first? You guys were just discussing.
I'm going first, so let me share my
Thank
screen.
you.
Can you hear me?
Yeah, we can hear and see.
Okay.
Perfect.
Great. So I'm actually I'm going to do a brief presentation. Will is very much a big part of this. So Will, please feel free to jump in as well. I don't know if Catherine is on, but she is. Catherine, please jump in.
Catherine's on vacation, but there may be, I invited the whole rest of the team, Fred, so maybe people will pop in.
Yeah, and I think I saw Tiara earlier. She's our research coordinator. So, anyone who's intimately involved in the study, please feel free to chime in anytime. So, yeah, I'll keep the presentation fairly brief, but this is really, the idea of this is to provide an update to the World Trade Center aging frailty study that some of us have been working on over the past few years. Catherine and Will have presented this, I think, a year ago at the time when we were preparing the grant application. So, part of this presentation will talk about the specific aims and objectives of the study. But very briefly, the World Trade Center Health Program is administered by NIOSH. It was established by the Zadroga Act in 2010, and it essentially provides free medical monitoring, treatment, mental health services, and benefits counseling for 9/11 responders and volunteers. There are multiple aspects of the program. There are 5 clinical centers of excellence, Mount Sinai being one of the 5. And I believe Mount Sinai has the largest center of the 5 centers. The centers do several things. It provides treatment for World Trade Center related certified health conditions. And in addition to that, it provides epidemiological surveillance by collecting and analyzing health data of the responders when they are seen annually at the health programs. So we, were able to tap into this resource to really further develop the study that I'm about to present. Within the WTC Health Program, there are approximately 80,000 enrolled responders who are part of this program. Research is done as a part of it and has focused on areas other than aging. I list them here. But given that this population, this cohort is aging with the median age of 59 as of last year, there really is an urgent need to better study the aging process in this cohort, do frailty assessments, better understand their cognitive physical function, so that again, that's the essence of what we're trying to capture with our study. With Catherine and Gallup Fellows leadership, we have developed a World Trade Center clinical frailty index to better understand frailty in this population. Frailty, as you know, is an at-risk state for increased vulnerability to poor outcomes. It's pretty common in older adults. So that hasn't been looked at in the population. And the different ways of studying frailty, and the approach we chose here is the frailty index, which is a deficit accumulation model of frailty. using data that are collected during these annual visits. And some of the examples, the variables are listed here. It's a 30-item index. And using this index, we found that a third of this cohort meet the criteria for frailty, and that frailty is associated with age, 9/11, exposure severity, occupations, especially those who are in constructions, and it is also associated with mortality. We did additional studies and analyses since the initial paper was published, one of which included looking at frailty trajectories within the general responders. So I'm sorry, move this to the right. You can move to the bottom. So we use latent clustered mixed models to analyze frailty trajectories. And what we found was that there were 3 distinct trajectories shown here. There's one group in red where the frailty index score started low and it increased gradually over time. There's a group where the frailty index started low, but increased fairly rapidly with age. And then there's a third group where the frailty index score at baseline is pretty high and that increased moderately over time. So there are different trajectories of frailty, which is consistent with the data and the results that are being reported in aging cohorts. Additional analyses were done to look at associations between various factors and frailty trajectories using multinomial regression analyses. And so far, based on our analysis thus far, it appears that frailty trajectories are associated with WTC exposure, sex, education, income, as well as occupation. We also looked into polypharmacy in this population. This histogram here illustrates the distribution of the number of medications. These are both prescribed and over-the-counter non-prescribed medications. The mean number of medications in this group is 6.1. Polypharmacy, defined as 5 or more medications, was present in 55% of the cohort. Hyperpolypharmacy, i.e. 10 or more medications, was present in 21% of the cohort. Many of them, 76% of them, also use medications that could increase risk for falling or the FRIDS as defined by these 5 categories. And these were the same medications and categories that were taken from the STRIDES falls prevention study. Some of the characteristics and associations of the cohort is shown here. So polypharmacy was associated with sex as well as obesity and some of these World Trade Center certified medical conditions, many of which are airway pulmonary conditions. The last piece of data I want to share is the pilot prospective cohort, study. So, again, our goal is to really understand the aging process. So part of that is to ascertain, geriatric conditions, assessments prospectively. So a pilot was conducted over the past 2 years in doing this. So we enroll over 100 participants from the general respondent cohort, and we piloted and tested the protocols to assess frailty as well as other geriatric conditions in this population. And some of the data are shown here, including an association between frailty and obesity, as well as the association of frailty with World Trade Center related certification, mental health certification. So these are World Trade Center certified conditions that are thought to be associated with the exposure, as well as association between fall risk and fear for falls. So, like I said, a lot of work has been done already. We're now, continue to build upon what we learned so far. The WTC U01 is a 4-year funded study. It started back in July of this year. The overarching goal is to assess whether WTC exposure can lead to premature age-related deteriorations in physiological function conditions in this cohort. The specific aims are listed here, and I'll go into greater detail in a minute. And ultimately, our goal is to improve the capacity of the health program to monitor and care for these aging responders. This is the study structure. It's a multi-PI study with Will, Catherine, and myself. The study personnel investigators are listed here. And as you can see, it's really a diverse group, of researchers with complementary expertise in making this happen. Our research staff are listed here, including Tiara and Caitlin, who are on the phone. I think very central to our study is the advisory board. We have a very diverse board that's run by Michael Crane, who directs the World Trade Center Health Program. And I think this expertise can really help us, with the implementation of the project, as well as the design, and the piloting of the interventions, which I will talk about. So there are 3 aims. And the first aim is to determine frailty trajectories and risk factors associated with the trajectories using data that we collected. So I've shown you some, data analysis that we have thus far. We really wanted to take it to the next level by looking deeper into the different risk factors, ideally modifiable risk factors that we could potentially intervene on, later on. Now, a limitation of this is that, we can only use data that we have. So, we will have to, figure out ways using collected data that's available to do these analyses. So polypharmacy and obesity, we have that data. Physical activity and nutrition, I think we will have to look into proxy measures of those. So again, the idea is to identify risk factors that we could modify and intervene upon with the hope of having a positive impact in terms of clinical outcomes. Aim 2 is to validate the index that I talked about using the frailty phenotype, the physical frailty assessment. There are different ways of assessing frailty. There's no gold standard, but that said, frailty phenotype is probably the most studied definition of frailty, and it has clear categories of patients who are frail, pre-frail versus non-frail. So the idea is to ascertain data required to identify those who are frail, and then analyze them so we can establish a cutoff using the frailty index. We will also look into the predictive value of this cutoff on geriatric outcomes that we are we're collecting and assessing in this cohort. Our goal is to enroll 400 general responders in our cohort. So the target is 20 enrolled participant per month for the next 20 months. We have different recruitment strategies that's being phased in. We have mostly focused on clinic-based recruitment. And as of last week, and the recruitment started in late October. And as of last week, we had enrolled 19 participants with 8 more who were interested, who were in the pilot study, who will probably be enrolled comes next week. And actually, I got an email a few days ago, so we'll probably have more than that. And then the last aim is a intervention aim. We want to adapt interventions that's been shown to be helpful in the treatment intervention in older adults, those who are frail. and to see if we could do the same in this population. So there are two specific areas of focus. One is deprescribing. I've shown you some data on polypharmacy, it's common. So, one of the goals here is to pilot and implement a pharmacist-led education deprescribing intervention that was developed in Canada, but to use that.
Pretty soon, yeah, that will, I think it's going to be over in a few minutes.
But to implement that in this
Yeah,
cohort with a target of 50 participants. And the second intervention is a successful healthy aging intervention. We plan on adapting the Healthy Steps for Older Adults, which is a National Council on Aging approved health promotion and falls prevention program, and to pilot that in 100 responders. We will be looking at the feasibility and acceptability of the interventions and explore geriatric outcomes such as the discontinuation of inappropriately prescribed medications secondary to this intervention. I'm going to skip this. I think we're pretty much on track in terms of what we propose to do. So, I want to open this up to the group, and Will and others from the research group, please chime in and elaborate what I've talked about so far. But we want to be able to answer any questions you may have about this study. We also listed some potential discussion topics that we could discuss as well. But I'm going to turn this over to Will and others.
Thanks, Fred. I just want to add one more thing is that, throughout the process of the preparation of this grant, and also actually now we are in the thick of setting things up, there is a lot of interest and support from the World Trade Center program that they do see, aging study and understanding how to help the World Trade Center cohort in their aging experience is a primary goal as the cohort ages, and so I think that's reflected in both the enthusiasm from NIOSH as well, our funder, and so we want to actually kind of really build on this project. What we said we would do is what we would do, but at the same time, build on this to say, to see what other opportunities there may be to build on this, to further the work, or even actually having it branch out or avenues for looking for future funding as well.
Does anyone have any questions or thoughts?
Well, I have one question. It's always so interesting to hear about this undertaking and this project. I guess I was just wondering, this may be on the more gerontological side. I'm sort of trying to figure that out, what that means myself and related to projects I'm, kind of thinking about. But I guess I wonder to what extent this population is defined not only by their sort of biophysiological exposure, but also their experiences, their sort of lived experiences of being on the front lines of 9/11 and the sort of social and cultural context in which their health has perhaps been informed or shaped, and also the sort of longer term, very contested politics that, around the responsibilities to care for them, the state's responsibilities to care for them. I mean, I'm thinking about that with respect to, VA, veteran experiences, also people living with HIV and their long-term experiences. And I guess that's just a more general question, but if you as a group have thought about that and to what extent those kinds of influences or factors or processes, come into the research or the investigation or the thinking about how they might respond to different kinds of interventions. So I know that's quite a big question, but it's one that is engaging me in my thinking about how to set up projects around these kinds of different experiences and populations. So this seems ripe for some of those things too.
Yeah, so a couple of thoughts on that. Oh, Fred, go ahead. Sorry.
So no, so I guess sorry, Will, I just jumped in. I'll share some thoughts, and then I'm really curious, Abigail, in learning about what you're thinking. What would your approach be to really look into this question? But I was going to say that I think what you're saying has a strong rationale. I do think past experiences, including those that are present in the environment, can really have an impact, a long-term impact on health outcomes, and on so many different levels. So one of the pilot study that we're collaborating with Megan Horton from Environmental Sciences is to see if there are associations between the exposome index that she has developed and frailty index that we developed, as a way to better gauge the potential impact of the environmental factors on frailty. But again, going back what I said earlier, I really would like to hear your thoughts about this, because I think you're probably thinking, some of the psychosocial aspect and caregiving aspect as well, beyond just the environmental exposures. And then, well, I'm sorry, I jumped ahead of you.
Yeah, not a problem. So I was actually just gonna say a couple more things. One is that our project actually is one of many projects that NIOSH actually supports through the World Trade Center sort of research program. And there are other investigators that are looking at more in terms of the psychosocial aspect of the lived experiences. And I am not as familiar with the literature, and we probably should, as we actually think through in terms of how does aging actually fit into all this picture of lived experiences, and how other investigators are actually looking at those questions and potential collaborations along the way, as we actually take aging front and center, but actually take into account of all of the experiences that make the World Trade Center cohort unique.
One quick question. You may have said this before and I missed it. Do you have assessments for dementia in the cohort?
Yeah, we have, so we're doing MOCA. So we do have a cognitive screening, assessment, I should say. Everyone is getting a MOCA administered, annually when they come in for their research visit, which we try to couple to their clinical annual visit. My understanding is that much of the cognition work is being done at Stony Brook. But how cognition and physical function and frailty, how they intersect in the population, it has not been looked at. So that's an angle that we can do in as well.
And I think also, I've heard interest in the extent to which environmental exposures can trigger onset of dementia. And there's very few places that can look at this. I know even when we did our strategic plan here at Sinai, there was interest in, kind of healthy brain, and then the opposite of that being like, what are some of the environmental epidemiological work around like dementia onset, and whether it's inhaling or like exposure to different environmental aspects. And there's been some work on it, some foundational work, I guess. I don't really know anything about that space, but that would be something that's like so unique in terms of this cohort and the longitudinal aspect. And obviously funding in dementia is great. So that could be kind of a, well, maybe not great, but relatively great. So maybe consider that angle a little bit as well.
Right. That's a great suggestion. I think one of the limitations as I'm learning about the cohort is that the actual exposure itself, and there are things that are, you know, capture, right? The amount of time one spends at the site on the pile, you know, exposure to the dust cloud. But in terms of the specifics, you know, the chemicals that are being, those are hard to quantify. And I don't know to what extent that data is available. So, you know, so I think that's something that, you know, that we have to look into, and it may limit the degree of the studies that we can do.
So,
Got it. Okay.
so I'm excited to find out more about this exposome that, you know, that actually characterizes exposure in more detail using available data. Our exposure variable has been limited to kind of like really high exposure, high, medium, low, but with a mix of different things that actually would be in there. And that's not a as straightforward in terms of when we think about pathogenesis of say dementia and trying to isolate what actually does bring about what you know, confer additional risk. But I'm excited to find out a little bit more about what we can actually derive from the data that is available to actually get a more refined exposure type of assessment. That could turn into an NIA grant, I suppose.
Yeah, one thing we didn't mention was that, you know, in Megan's pilot study, she has a lot of expertise in looking at brain phenotype using, you know, MRI and functional imaging. You know, she's planning to look at doing that, you know, in patients who are frail versus non-frail. The logistic could be more complex than I make it sound, but I do think that, you know, the findings may be interesting, and you could, you know, you could lead to additional studies later on. But yeah, thanks for that, Melissa.
And I would say that that's one more thing that when we asked Michael Crane, who is the Walsh Center Clinical Medical Director, about, you know, what are the concerns of the Walsh Center cohort as they age? One of the really big concerns is cognition. You know, frailty, sure, but cognition is actually one of the main worries that that the cohort has. So we definitely do need to actually, you know, even though we haven't been in that space, really do need to see in terms of in that with this grant opportunity and potential, you know, Pepper pilot and other grant mechanisms to kind of shift to actually really look and build that into the way that we look at aging.
Yeah. I agree. All right. Well, thank you. This is great. We'll look forward to hearing more about this. Thanks, guys. Jenny.
All right. Hi, thank you guys. Here, let me get this. How's
Perfect.
that look? Reasonable? Good. So, okay, so I'm very excited to present. So I think I've presented different stuff over time, but as people may or may not know, I am in the third year right now of a K-23 that's had some quantitative work and one really big qualitative project doing triadic longitudinal qualitative interviews. And Deborah Watman is here. Deborah has been my partner for all of it, for interviews, for analysis. And I think we're at a really interesting point. So we've completed all the interviews and we are thinking, I mean, beyond thinking about analysis, we've been thinking about analysis for a while and are trying to figure out sort of how to put everything together. So in this presentation, I'm going to give a little background and then really try presenting the results that we have and sort of what we're going to with interpretation. And I'm very interested in what the group thinks, what you guys think about, you know, what hangs together, what doesn't, what's missing, and if if the conclusions that we're coming to really seem to be driven by this kind of massive amount of qualitative data. So here we go. So this is the project. So, tiny bit of background, but the idea is that as people, as dementia advances, paid caregivers, so this is kind of my usual home health aides, the whole group of people, not just with Medicaid, kind of all comers who are providing paid care in the home, that care is often needed, but we really just don't know how they work with the team. What we do know really is that paid caregivers do a lot, right? So they provide sort of hands-on support, but they do a lot of emotional care. They're supporting with health tasks. They're very involved in care, particularly as dementia advances. And it is sort of in this group, these people with like more progressive dementia, where they're doing more and more. And we also know that paid and family caregivers work together. So it's not just like you get a paid caregiver and then the family caregiver takes a break and comes back on later on. Like there's a lot of working together. And we also know that paid caregivers really are not integrated in the healthcare team. It's really sort of like a kind of side thing, generally not communicating with doctors, maybe some communication with nurses, but not even a lot there. So this project used, like I say, we used triadic longitudinal semi-structured interviews. So basically how it worked is we identified people with moderate to severe dementia, identified by geriatricians at each of the Sinai outpatient practices. And we recruited their primary family caregiver as identified by the geriatrician, and then the primary paid caregiver as identified by the family. And then we enrolled or recruited that geriatrician. And so we did basically 3 interviews, an initial interview that kind of asked about paid caregiver roles, and then follow-ups that focused on changes and exploring some of those topics that came up. And then used the framework method of qualitative analysis to sort of look at, both look directly at what people are saying, but also to try to kind of compare different roles, different triads. And so we ended up with 29 unique respondents. 2 of the triads had a change in the primary paid caregiver. So we ended up sort of recruiting a different paid caregiver for a group of the interviews. And that totaled 75 interviews. Which is a lot. So this was a huge amount of data and not something I had been used to dealing with quality. Like I had like 20 people or interviews. So, or dyads. I did do a dyad project for the Pepper pilot way back, but again, this was a lot. And I think what was also really interesting here, and that we've been trying to kind of figure out how to process, is that there's really different buckets of data. So there's the level of the respondent, right? So it's the family caregiver gave an interview, or the paid caregiver, or the geriatrician. You can kind of look at direct quotes for that. But then there's also analysis at the level of the triad. So it's like we almost like are hearing all these different perspectives. And when you put together what the family says, what the paid caregiver says, what the geriatrician says, you understand sort of what's happening at that higher level. But that data is not coming from the direct quotes exactly. It's an interpretive sort of step. And I also think it was important sort of what wasn't said. There were questions we were asking, there were things that we were interested in that people did not talk about. And so that's, there's something there. And I've talked to Deborah about this a ton, and also Abigail and Emily, in this project, qualitative analysis has really been active. And I think it's made me really realize that, that qualitative analysis is not just sort of regurgitating what people say in interviews. There's a lot more of trying to understand how people put together. So this is my effort to sort of put all these things together, but really, we appreciate any insights about how to present the data with clarity. And again, if we can kind of come up with some really summative findings that reflect the depth of the data, that would be the ideal. So just to start, this is a very kind of basic sociodemographic, but looking at who we talk to. So it's interesting. We didn't talk to the patients, but the patients are sort of at the center here, right? So mostly female. 2 of the 9 were totally ADL dependent. Some people walked, but many people, were able to feed themselves, but more in the sort of moderate, tending towards severe dementia. And 5 of them had 24-hour paid care. The family caregivers were, mostly women, mostly daughters, and actually mostly working. So many were working full time. The paid caregivers were all female. Only 2 were born in the US, and 2 people had English as their first language. They worked different amounts of time. So there were people who'd been a paid caregiver for 3 months, people who'd been a paid caregiver for 18 years, and that same range for caring for these patients, 3 months to like 17 years. So a wide variety of experience there. And with the geriatricians, interestingly, all female here too, but relatively new providers attending for maybe 4 years up to 32 years. And the geriatricians have been caring for the patients here for sometimes less than a year, a few months, up to 8 years. So a lot of variability here. So this is our effort to kind of capture, the triads, right? Because a lot of these factors are sort of similar. So here, this column, the numbers, because of the way recruitment meant, are not chronologic, but there's 9 of these guys. We should probably adjust that. But just to give you a sense of sort of the care arrangement. So here you can see kind of by triad, only 2 people actually lived with family members, but there was a wide range of care per week. And those people who lived with family members tended to have, 30 hours, 40 hours of paid care per week. But people who didn't sometimes had a lot. So 168 is sort of 24/7 paid care. For one individual, it changed over time. We can see then the number of paid caregivers. So most had 2, kind of splitting care. One had 3, and one individual had 8. So had like 12 hours and 12 hours paid caregivers, and 2 on during the day. So it was a full house with a lot of care. You can see, 5 were Medicaid funded, and most of those who were Medicaid funded worked through a home care agency. There was also a private agency. So again, things were set up in very different ways. And this is a graph that I've been working on with Deborah. Basically, we're just trying to capture this variability. So this graph really is focusing on that relationship between the person with dementia and that primary paid caregiver. So the person we interviewed. And what on this, here we can see the hours per week with that individual with dementia. So like number 8, for example, is somebody who was with this person 24 hours, 4 days a week. And kind of it goes down from there. And then we see how long they work together. So quite a few, the majority of the aides had been caring for that patient for, between 0 and 2 years. But we have this outlier here at 17 years, and other people who were 5 or 6. So again, just sort of getting at the variability. And what you can see here too, we looked, a little bit about dementia training. A lot of people talked about some dementia training. We don't really know how relevant that was, but it was pretty common to have some amount of dementia training. That's the full box versus the hashtag box, or the hashes box. And then color-wise, there were 2 triads, like I say, where the paid caregiver changed. The primary person we interviewed changed. For most people, it was stable over that 6-month period. And, in these follow-up interviews, it's an interesting experience. I mean, you really know what's going on with these people, right? And a lot happened. And I guess one of the sort of framing things that I don't quite know where in the discussion to mention, but is basically that we had hoped to, or I had initially planned to do this for 12 months. I had additionally planned to do a 1, 3, 6, 9, 12. And I actually ended up stopping at 6 months because, the reality is things happened, a lot happened, right? So 3 people died. A lot of people had functional decline or cognitive decline. There was a range of hospitalizations, families changed, paid caregivers changed. But what we were really interested in is that paid caregiver role. And that didn't change so much. The kind of setup and the way people did things remained the same over time. And I'll come back to that in a minute. So how do we characterize the triads, right? So this is sort of the level of analysis saying, okay, we have information from so many people about what's going on in the care of this patient. How do we sort of put that together? And what were, oh, sorry, I just realized there was a chat. I didn't look. Yes, 2 of the triads were paying for 24/7 care out of pocket. Yes, absolutely. 3 of the triads basically were Emily. And thanks, Melissa. We're working on the graphic. That's another piece with this. It's like, how do you display this? So to return, so this is, thinking about the nuance within the triads, thinking about kind of what is really going on here. We tried to characterize it both by looking at sort of the overall home care situation and then the overall paid caregiver role. And we characterized the triads using a quote from, that came up. So the first triad, we're doing the best we can, is how something the son said that characterized it. Basically, this is a patient who doesn't have enough care. He's alone at night, totally unsafe. His son can't stay with him and they can't afford any more care and they're not qualifying for more through Medicaid. And in this triad, the paid caregiver is really, taking ownership over things, but keeping boundaries because she can't fix it all. And she tries to fix it when she comes in the morning, but like kind of letting go the fact that, there's a lot of chaos happening at night. The next triad, the daughter described that the paid caregiver takes the edge off. So this was a triad where the patient lived with her daughter who was kind of having a hard time managing, and the paid caregiver just basically like gave the daughter a break, right? And that was the paid caregiver's role. She was warm, she was very loving, and it was really just being there with the daughter or with the patient during the day. Then we had one, this is the 8 paid caregivers. The daughter was very clear that she was the CEO, right? She oversaw this team of multiple privately hired caregivers. They worked together. They were very efficient. The daughter sent them all to a dementia paid caregiver training. And that primary paid caregiver in this circumstance was actually the woman's housekeeper before she needed paid care. And once she had a bad stroke, her housekeeper stepped into this role of really managing not only the household, but also all the paid care tasks. The next one, the daughter kept saying that paid caregivers are professionals. This too was private paid care. The daughter lived far away, and she basically she worked with an agency. She saw the agency as having well-trained aides, and this was their job. They were professionals. And the paid caregivers too felt very empowered to do things and were very connected to their private agency. And we had another triad where it was a sister speaking who said it's not the paid caregiver's job. So this was a sister. She lived at home with her sister with dementia and a brother who had Down syndrome. And the sister sort of had this very narrow definition of what the paid caregiver would do. And the paid caregiver did a great job, but it was very specific, very, very clear boundaries for how she was engaged. And this triad, the paid caregiver, is actually the one who said the daughter and I are both alpha males. So the daughter lived mostly in Puerto Rico and basically delegated a lot of the aspects of care to this aide who was very competent. And the doctor knew this aide was the point person for that person's care. There was a paid caregiver who said that the aides need to be mature. So this patient had 24-hour paid caregivers, but the daughter kind of kept changing them around, sort of feeling like they weren't able to do a good enough job taking care of her mom. And the daughter, even though she didn't live there, was very, very hands-on and very sort of micromanaging those tasks. Had a son who described it as all improvising. So he was working really hard to create this like family-like environment for his father with dementia and also his mother who lived there. And in this case, the paid caregiver really, talked about warmth and love, but very much deferred to the son as in charge of everything. And in the final triad, it was actually the physician's quote that rose to the top that, I'm more concerned about the other stuff. So this was a very chaotic home situation. The daughter was the family caregiver, but there was a son who had drug problems and mental health problems who sort of kept sabotaging the care in both sort of like kind of behind the scenes way and also in very sort of concrete ways. And honestly, everybody was just trying to deal with these complicated family dynamics, and the paid caregivers sort of shuffled through as they were dealing with bigger things. And so we also kind of looked at themes in a more traditional way and identified a few really key themes that really applied to all triads in varying ways and all participants in varying ways. So the first really main finding was that families were the ones driving the paid caregiver role. And honestly, both the paid caregivers and the geriatricians deferred to families. Sometimes the paid caregivers did more, but it was very much with sort of like when they were delegated to it by the family. The family was really running the show, which was true regardless of private pay, Medicaid, agency, not agency. The families acted as sort of an intermediary between the aides and the doctors. So, you know, the aides talk to to families who talk to the doctors, right? And sometimes there was outreach to the paid caregivers, but mostly as a way of getting information, you know, just saying, did that person move their bowels? Did they eat? Did they do this? But sort of, they didn't interact directly most of the time. And there was one perspective, like I described, the alpha male paid caregiver who was actually the point person for everything. Similarly, the role of the formal care plan. So in home care with agencies in particular, there's like a list of tasks the aides are supposed to be doing that's updated about every 6 months or so. And pretty much across the board, everybody said that wasn't super useful. The only kind of other perspective was that private agency. And in that setting, the agency actually played a bigger role. So individual who was private paying an agency to provide aides to care for her mom. And another thing that emerged was that there was different paid caregivers have different roles. So in this group, people had, you know, multiple paid caregivers. There was often like a primary person, and people talked about different personalities, approaches, and strengths and weaknesses. So it wasn't like there was one that was better, but often the different people had very different perspectives. And then there were themes that really seemed role specific. So this was that framework form of analysis kind of lets you look at some of these themes by respondent. So when we looked, it was really the paid caregivers who were talking about this sort of emotional connection, investment in families and patients, feeling like family, the whole sort of emotional component of this care delivery. It was the paid caregivers who talked about it. And the families sometimes confirmed it and talked about that too. You know, we asked questions like, what's the main thing this paid caregiver does, right? Families sometimes talked about this emotional connection, but not that much. And physicians, it was even less. Physicians really discussed that kind of emotional role much less. Kind of similarly, this sort of day-to-day teamwork was really important for paid and family caregivers. There were lots of different ways people tried to communicate and share information, but this wasn't something that the doctors talked about. And you know, what didn't people talk about overall? Like I say, as we did these interviews over time, things changed in people's lives. But the way that the paid caregiver engaged didn't actually change that much, even as people were declining. And this may be some that we are catching people with more moderate or severe disease. We're not seeing that transition from like no paid care to some paid care. But it was notable that, there was a system that worked and then that system continued. It was also sort of interesting, geriatricians, which, they didn't know much about the dynamics in the triad. And basically, like, it kind of seemed like they didn't know much unless there was really a reason for them to be involved. And so in that last triad where the family was so chaotic and there was so much going on, the geriatrician knew everything about like the aides and what was going on. But in many of the other ones, they didn't get into it unless they had to. And, we're also doing a separate, more sort of straightforward analysis, just looking at geriatrician perspectives overall when paid care plays this big role in care, because it seemed like they may not know for that individual person we were talking about, but they did have a lot of ideas because there were all circumstances they could identify where they really did know about the paid care, but again, not for all patients. And finally, we did, like I said, I've said this before, but I think it was notable: agency versus no agency, Medicaid versus private pay. It didn't seem to matter as much on paid caregiver role. And, as we've tried to kind of put all of these data together and think about what it means, the idea that sort of keeps coming up is that, is that centrality of the family. And I think this idea of family-centered home care, which is kind of common in pediatrics. People have talked about it in other settings. But I think we talk about patient-centered home care, person-centered care, but it kind of seems like in this home care setting, it's really family-centered care. So not, not that immediate, maybe nuclear family in the same way, but family in the sense that this whole picture of what's going on, the needs, the environment, the family expectations, the family preferences, it's sort of, this is what's driving what the paid caregiver does. Because in general, there were more differences between the triads than there were within the triads. Like people were kind of on the same page, for the most part, small differences, but overall people thought about care in the same way. And, it really seems that the care that they received was sort of molded to that, to the reality of the context. And I think this is a good way to think about it because, hearing these paid caregivers and family caregivers and geriatricians talk, like sometimes the paid caregivers really seemed like family. I mean, sometimes they're, they talked about like the one who had been there 17 years, she kind of felt like she knew more about what the patient really needed than her family did. She saw herself as family. But there were other settings where the paid caregiver kind of came in, did their thing, and maybe did a really great job and then left. So I think those differences were important. And I think what drove those, like we say, was kind of this bigger picture of the family, system that was there in the home. And again, it's not just about payer or agency. There's more to what's happening in that kind of unique setting that drives what people do. So I think the implication for this is basically, this is something I've struggled with a lot. Like, it's like, do you have an intervention? Like, what do you do? What does this mean? And I think like, to me, what it means is that things that are very prescriptive are just not going to work. They don't reflect the reality of what happens. Like the work, even though, paid caregivers in the home have a lot in common training wise with CNAs in like nursing home settings, for example, the home setting is just different. You can't, it's very unique, and it's not so easy to create checkboxes of what you're supposed to do. So instead, I think it's really about communication and expectation setting. And, rather than kind of having a care plan that's very specific that nobody follows, to really dig into this idea that the plan and what needs to happen in those roles and how they play out are part of a very family-centered and person-centered sort of decision-making and planning process, which again is harder to do, but I am really struck by the idea that like, the one-size-fits-all thing does not work. And so things that sort of perpetuate that model either will fail or will just sort of be irrelevant, because what happens when people are actually there is very different than what it looks like on paper. And so I did not leave much time, and I'm really sorry, but I would like to hear what people think, even in other settings, because this is my first effort, like I say, to sort of put it all together. And I don't know if it worked. So anyway, in the couple minutes left, questions or comments, and thank you guys for listening and letting me talk through it.
This is amazing work. I really, I see the value and how much it helps to have the triage of perspectives, because I've never heard all of those same comments like that put together. So I think it's incredibly informative. It makes me wonder about like, how do you, and I get your point about it's just so diverse and maybe we shouldn't say it should be done this way, but then how do you, I don't know what the state of like quality measurement in paid care is, but how do you even approach that then? Like what's being done around that space? And what should be done?
My eye, the lucky or unlucky part, depending on the way you look at it, is nothing is being done, right? So like the quality metrics are like, did the aide show up on time? Which, you want them to show up on time, but like, nobody is kind of digging deep here. So I think that is So it's certainly like not pushing against something, where I think the implication piece actually falls maybe is around the idea that this is dementia, because I think like what I think is that there are circumstances where, you have somebody who's cognitively attacked with fairly straightforward needs. Like you do want a checklist. You want somebody to come in and bathe them and do shopping, and then they need to go home. Like, but when you have these complicated people, that might be the time to do it. So I think like, to me, that's the implication, is that you don't need this for everybody. Like you don't need to sit down and have this whole thing. But if you have like 24-hour paid care, funded privately or through Medicaid, what's going on and what does that look like? And the person has dementia, like it's worth investing more in that. And so I think that's it. I mean, and I think the lack of quality metrics, or the lack of this conversation happening really in the workforce space, because everything still is very prescriptive, and like you do your care plan and nobody quite acknowledges this depth. Like, I think that's the spot where maybe you step in and say, for dementia, if we're going to keep everybody at home, this is what we need. Yeah. Chris?
Really so cool. One thing I was thinking of while you were just talking is that, I wonder if this work could sort of direct you towards like what is, you're focusing on the differences, but also like what are the common elements, and like what would the floor be of of that checklist? Like, yes, not everything's required, but there's gonna be like a few things that's like the floor of like showing up on time. Or reasonably close to on time. And then the other thing I was going to say is when, just sort of like how to make the arguments about the differences, you might, one way to do it, I guess, would be like, you'd have to change stuff for anonymity purposes, but like really do a deep case description of like the 3 most disparate cases.
Yeah. And
then sort of like bring together your argument, bringing in the broader, like tabulated data from all of the interviews.
Yeah, that's a good point. Yeah, I mean, and that is like, I struggle with this, like, how do you kind of get everything in the same project? Like other projects I've done that have been bigger, like with qualitative analysis, you can kind of like cut off a part, and you have one paper that does this and one that does this. But I think the whole point of this is like, is that big picture. So it may be that, those sort of like vignettes. Yeah, it's an interesting idea. Okay, I'll think about it. It kind of depends where you write this up and publish it. The problem is that like, I'm not as super into the theory of the gerontology piece. I kind of like the sort of applied lived thing, but those journals like short articles, and then the gerontology ones like so much theory, and I don't. So anyway, I struggle to think that a little bit, but I will definitely think about that.
Mohammed and Emily just have comments in the chat too. I just want to make sure you see that.
Oh,
I know we're at
right.
time, so we can. I have a lot to ask you about this, but we can.
Yeah, I have
separately.
to like ask you all too next time I talk to you what you guys think, because I've been spending a lot of time trying to figure this thing out. Oh, Mohammed said, which I think is interesting, the other support in families, and I think that's a really good point. We do have that, like either who else the family caregiver is caring for, and who else is helping them, and people's. I mean, it's their perception, obviously, of how much help they have. People don't perceive to have a lot of other family help, but that's an important thing that we have asked and explored and coded and have, that I should definitely include in these in the findings. I think that's important. Yeah, and Emily, high functioning teams. Okay, thank you guys so much. We can get off. Please let me know if you have thoughts, and we'll, like I say, I'll ask you all this again next time I see you.
Thank you, Jenny. That was amazing. Thank you very much. And thank you, Deborah. Graphics were good too. We're very excited about graphics these days, trying to do better with those. So thank you. Thanks to everyone. Great to see you, and happy holidays to everybody. And we'll see you after the new year. Thanks.
Happy holidays, everyone.
Happy holidays.
Bye.